Good evening. Can you please settle down? We'll start off today's meeting. I think people will join because of the rains. I think it is getting a little delayed, but we'll start off. This will be the last monthly meeting for this year. September next month it will be a national meeting at Amritsar, and then in Jan we have our annual meeting at Yerkad. So after this meeting, probably we'll be meeting again only in Feb. So again, this meeting, as usual, we have a packed session ahead for the next three hours. Initially, it will be a postgraduate session for 1.5 hours, followed by CME part. So I request Dr. Ganesh, our president, to give the welcome address.
Good evening, all. It gives me great pleasure to invite you all to today's monthly meet of our society. And I hope some people will join with unusual rains and all that. But we have a full, busy and interesting session to be kick-started by a panel by Bharat. But before that, we'll have a journal session, scan, and then followed by the panel discussion. I also take pleasure in inviting two of my friends who are going to give special talks. One is Dr. Paul from USA. I think he is joining us. And he's got a lot of followers on his YouTube videos. So I think he'll give us an interesting talk on gut-friendly food. Followed by Dr. Sujata of Adyar Cancer for GI cancer prevention. And we round up today's talk with gastrotakis. I think I'm also as interested as you all to know what is this gastrotakis by none other than our own friend Seshadri. So I request Dr. Anand to kindly take over and start the proceedings. Wish you all a wonderful evening.
Good evening. I think there is a slight change in the program. First, we will have journal scan by Dr. Anusha. And I request all people to take the center seats. Don't be in the back. It will be like a vacuum here. Please come.
So good evening all, respected faculty and dear colleagues. I am Dr. Anusha A, second year senior resident from Institute of Medical Gastroenterology, Madras Medical College. And I am here to present a review on recent publications in India on pancreaticobiliary disorders. So moving on to the first publication, it is on a cross-cultural study translating and validating the Compat SF pain questionnaire in Telugu, Bengali and Hindi. This was published in the Indian Journal of Gastroenterology in September 2025. It was a prospective observational study conducted in AIG Hospitals, Hyderabad and AIIMS, Delhi, and the authors were Emenutsa et al. So the Compat SF questionnaire is also the comprehensive pain assessment tool, short form, and it is the only validated pain assessment tool for chronic pancreatitis. Since prevalence of chronic pancreatitis is high in India and we have majority of cases of tropical pancreatitis, there is a need to validate this questionnaire so that it is available to all our Indian patients. So the original version of Compat SF questionnaire consists of 6 questions divided into 5 pain dimensions: the pain severity, the pain fluctuation, pain provocation, spreading pain, and qualitative pain descriptors, including the nature of the pain, the site, the location of the pain, and the radiation of pain. So this was conducted from June 2022 to January 2023, and patients with CP aged more than 18 years with at least 3 years of abdominal pain were included in the study. So what they did was that they took the English questionnaire, they translated first into the Hindi, Bengali and Telugu versions, and they had back translated it into English. And then following an expert panel discussion, it was given to 19 Hindi patients, 30 Bengali and 18 Telugu patients. So after 3 weeks of gap, the English questionnaire was also given to these patients to ensure the concurrent validity. So after the validity and the reliability testing, it was found that the data collected from the translated questionnaires fit the original questionnaire well with valid answers. The strength of this study was that it involved a meticulous translation process and it adhered to the international standards and involved multifaceted validation process. But the limitations were the constrained sample size and there was inability to measure concurrent validity in Bengali and Telugu because they couldn't get speakers to back translate it into the English version. So these translated versions actually helps the healthcare providers to improve the quality of life in chronic pancreatitis cases in India. The second publication is on rescue cannulation techniques in difficult biliary access, a comprehensive review, which was published in the Indian Journal of Gastroenterology in June 2025. It was conducted in PGMER Chandigarh by S. Mandavare et al. So the key step in ERCP, endoscopic retrograde cholangiopancreatography, is the visualization of papilla and achieving the successful cannulation. So difficult biliary cannulation is defined as presence of one or more of the following: either more than 5 contacts with the papilla while attempting to cannulate, more than 5 minutes spent attempting to cannulate after visualization of the papilla, or more than one intended pancreatic duct cannulation or opacification. And the American Society of Gastrointestinal Endoscopy defined the DBC as inability to achieve selective biliary cannulation within 10 minutes or up to 5 cannulation attempts or failure to access the major papilla. So the factors that are associated with DBC include the size of the papilla, especially a small flat papilla or a large protruding pendulous papilla, the location of the papilla as well as presence of periampullary diverticulum, post-surgically altered anatomy, distorted morphology because of an impacted stone or malignancy, and iatrogenic, especially papillary edema secondary to repeated cannulation attempts, and inexperienced endoscopist. So the rescue cannulation techniques include the 3 methods: freehand method, and we have the wire-guided method, and EUS-guided rendezvous technique. So among the freehand methods, we have pre-cut papillotomy and pre-cut fistulotomy. So in this diagram, they actually show the pre-cut papillotomy, in which the incision is usually placed over the papillary orifice, more commonly from below upwards, and so that until we see the pinkish white mucosa of the CBD, and then cannulation is attempted. But whereas in pre-cut fistulotomy, the incision is placed above the papillary orifice and at the 11 o'clock direction, and then the cannulation is attempted. So selective biliary cannulation rates in pre-cut papillotomy is 89.3% and pre-cut fistulotomy is 95.7%. But incidence of adverse events such as post-ERCP pancreatitis was similar in both the methods. And we have the try another day technique, where we reattempt ERCP after 2 to 3 days of unsuccessful cannulation, and it had a success rate of 79%. And we have the wire-guided methods, transpancreatic pre-cut sphincterotomy and double guide wire technique. So in this transpancreatic pre-cut sphincterotomy, actually the guide wire is first placed inadvertently into the PD, and then later sphincterotomy is done at the 11 o'clock direction, keeping the guide wire in the pancreatic duct. Whereas in the double guide wire technique, the PD is cannulated and the guide wire is placed, and then secondary to that, a sphincterotome along with the guide wire, the sphincterotomy is done at 11 o'clock direction, and then the guide wire is placed into the CBD. But PD stent has to be placed in both these techniques post-cannulation to prevent post-ERCP pancreatitis. And the success rates were 90% and 82% respectively in transpancreatic sphincterotomy and double guide wire technique. And higher rates of post-ERCP pancreatitis cases were seen with the double guide wire technique. And we have the US-guided rendezvous technique, which is usually indicated when these methods fail or in surgically altered anatomy. So actually in the EUS guided technique, what they do is the EUS scope is positioned in the D1, and then the intrabiliary axis is attained through which the guide wire is placed, and then the guide wire is retrogradely passed into the papilla. So once in the papilla, the guide wire has reached the papilla, then the EUS scope is replaced with a duodenoscope, and through the guide wire, the cannulation is attempted. So the success rate was 86.1% with adverse events of 14%, and it requires more expertise. And in surgically altered anatomy, use of pediatric colonoscope or enteroscope or EUS guided interventions can be helpful. So the conclusion of this review was papillary anatomy dictates the rescue cannulation technique. So what they said was that if there is a case of difficult biliary cannulation, and if we have inadvertently cannulated the PD, then depending on the papillary morphology, if it is a type 2, then double guide wire technique is preferred over the transpancreatic sphincterotomy. Whereas in type 1, 3 and 4, transpancreatic sphincterotomy is preferred. And if the PD was not cannulated, then depending upon the papillary morphology, in type 1 and 3, usually fistulotomy is preferred over papillotomy. Whereas in type 4 and type 2, papillotomy is preferred. And if these methods fail, then we go for EUS guided rendezvous technique. The next publication is Long-Term Outcomes of Pancreaticoduodenectomy for Groove Pancreatitis, a retrospective experience from a tertiary referral center. So this was published in the Annals of Hepatobiliary Pancreas Surgery in June 2025. It was a retrospective review. It was conducted in AIG Hospitals, Hyderabad by Ahmed et al. So groove pancreatitis is defined as inflammation of pancreaticoduodenal groove, and it is usually suspected in younger alcoholic males with abdominal pain, and there is often a radiological evidence suggestive of groove pancreatitis. So pancreaticoduodenectomy is most commonly performed surgical procedure in cases where the conservative and endoscopic management fail or in presence of complications such as duodenal obstruction. So this review was aimed at reporting long-term outcomes of PD in a tertiary referral center. So this diagram again shows the groove pancreatitis. So it was a retrospective review which involved histopathologically confirmed diagnosis of groove pancreatitis and who underwent Whipple's pancreaticoduodenectomy from 2010 to 2024. So they had collected all the comprehensive clinical history, the blood investigations, the details of endoscopic, EUS and radiological assessments, the intraoperative surgical details and the postoperative courses. And follow-up was also conducted by a telephone-administered questionnaire. The conclusion of this review was that the most prevalent symptoms were abdominal pain, recurrent pancreatitis, and gastric outlet obstruction. And the median age was 45 years, and there was an association with smoking and alcohol consumption of 80%. And the most frequently observed imaging findings were pancreaticoduodenal groove inflammation, duodenal wall thickening, and intramural cystic changes. And surgical treatment achieved pain relief in 73% of the cases. And post-Whipple's morbidity was seen in 52% of patients with major complications in 21%. And the most common complications were delayed gastric emptying, post-pancreatic hemorrhage, and pancreatic fistula. And new onset diabetes mellitus and steatorrhea were seen in 42 and 21% cases respectively, and significant weight gain was seen in 71% of the cases. So this actually addressed the disparity of the data on epidemiology, management, and outcomes of groove pancreatitis in a nation context. But the limitations were the limited sample size, exclusivity only to patients who underwent pancreaticoduodenectomy, the retrospective nature, and absence of data on patients who had received conservative and endoscopic management. Now, the next publication is on outcome of percutaneous transhepatic biliary drainage, a retrospective study at Tertiary Care Referral Center. So this was published in Egyptian Livers Journal in September 2025. It was a retrospective observational study conducted in Department of Surgery, JIPMA, Pondicherry, by Kumar et al. So PTPD is a minimally invasive imaging-guided procedure for biliary drainage in cases where ERCP fails or is impractical. And degree of ISGBRD is important for the technical success of PTPD. There are risks of complications such as hemorrhage, bile leak, catheter dislodgement, or blockage. The diagram again shows the PTBD procedure. So the clinical, demographic, laboratory details of all patients aged above 18 years who underwent PTBD from January 2019 to December 2022 were collected. The primary outcome measured was the effectiveness of PTBD in reducing the serum bilirubin, and the secondary outcome was on the assessment of post-procedure complication. So there was a significant reduction in serum bilirubin levels to below 3 mg per deciliter in 69% of the patients. That is around 89 and 128 patients by 4 to 6 weeks. And 80% of patients had reduction in serum bilirubin by 25% in 2 weeks post-procedure. And the most common cause for failure of PTBD were, that is the failure to reduce serum bilirubin post-PTBD were the hilar cholangiocarcinoma and carcinoma gallbladder due to non-confluence of the IHBRD. And there was no significant difference in morbidity, mortality, and success rates between left and right-sided biliary drainage, and lower rates of reduction in serum bilirubin was seen with bile stones. And in-hospital mortality was 13.2%, with higher rates in patients in cholangitis and with post-PTBD, bile leaks, and vascular injuries. So this Kaplan-Meier analysis actually shows that there was a significant difference in the survival outcome in patients who underwent surgery after PTBD, and in those who did not underwent surgery after PTBD. But there was no statistically significant difference in patients who underwent chemo or who did not underwent chemotherapy post-PTBD. So it is an effective method for biliary drainage in patients with obstructive jaundice, optimizing serum bilirubin levels and rapidly decompressing the biliary system in cases of cholangitis. The next publication was on pancreas divisum, the culprit or an accomplice in pancreatitis. So it was published in Indian Society of Gastrointestinal Abdominal Radiology in June 2025. It was a retrospective observational study conducted in AIG Hospital, Telangana by Kotta et al. So pancreas divisum is the most common developmental anatomic variant of pancreatic duct, which occurs due to failure of dorsal and ventral pancreatic annulage in the 6th to 8th week of intrauterine life. So its prevalence ranges from 5 to 14% in general population, and ERCP is often considered as a gold standard for diagnosis of PD. So this diagram shows the 3 types of pancreas divisum. Type 1, where there is a complete non-fusion of the dorsal and the ventral pancreatic duct. Type 2, where there is only the dorsal pancreatic duct. And type 3, where there is a residual connection between the ventral and the dorsal pancreatic duct. So often pancreas divisum is labeled as a cause for idiopathic pancreatitis without adequate evaluation. So this study was aimed to assess the prevalence of pancreas divisum, of its types and its association with idiopathic pancreatitis in the Indian subcontinent. So they had retrospectively analyzed MRCP studies from December 2023 to May 2024 for pancreas divisum and imaging features suggestive of acute pancreatitis, recurrent acute pancreatitis and chronic pancreatitis. And evaluation for other causes for acute pancreatitis were also reviewed. So this is the MRCP report showing the type 1 pancreas divisum, the type 2 pancreas divisum and the type 3 pancreas divisum. So conclusion of the study was that prevalence of pancreas divisum was 3.5% in general population, but there was a higher prevalence of idiopathic recurrent acute pancreatitis of 20 to 25% and idiopathic chronic pancreatitis of 41% in the general population. And higher prevalence of pancreas divisum was seen, around 6.2% among the idiopathic pancreatitis patients. But there was no statistically significant difference in the etiological factors causing pancreatitis in the pancreas divisum group and the non-pancreas divisum group. So they had concluded that pancreas divisum might only increase the susceptibility to pancreatitis. And they have also said that only a subset of cases with pancreas divisum and who have higher intraductal pressures may respond to endoscopic or surgical therapy. And there was no statistically significant difference in the prevalence of idiopathic pancreatitis in each type of pancreas divisum. The strength of the study was that it is the largest study collected from a single institution based on Indian population, and there is a lack of genetic workup. The next is on pre-procedural screening for multi-drug resistant organisms in endoscopic retrograde cholangiopancreatography, an international multi-center cross-sectional observational study. So this was published in eClinical Medicine in November 2025. It was a cross-sectional observational study conducted in AIG Hospitals, Hyderabad by Plog et al. And ERCP is often considered as a gold standard for treating biliary, liver and pancreatic disorders. But reusable duodenoscope often poses a risk of transmission of infections leading on to duodenoscope-associated colonization and duodenoscope-associated infection. And the risk is higher with the presence of multi-drug-resistant organism. So the objective of this study was that the primary objective was to assess the MDRO carriage among patients undergoing ERCP in countries with differing expected prevalence rate. And the secondary objective was to identify the risk factors for pre-procedural MDRO carriage in this population. So this was conducted between 22nd January 2022 to 9th October 2024 in 4 tertiary care centers in India, Netherlands, Italy and US. Demographic details, the medical history, any history of use of antibiotic or antacid or PPI in last 6 months, history of clinical admissions exceeding 24 hours in past 1 year, ERCP and other details of endoscopic procedures were collected in the past 6 months. And before the ERCP, a throat, nose and rectal swab were taken and sent for culture. The tested MDROs included extended spectrum beta-lactamase producing enterobacteriales, carbaminase producing enterobacteriales, carbaminase producing Pseudomonas aeruginosa, resistant Acinetobacter caloaceticus baumannii complex, vancomycin resistant Enterococcus faecium, and methicillin resistant Staphylococcus aureus. So MDRO prevalence measured in India was around 83.1%, and chronic lung disease, congestive heart failure and prior use of penicillins were associated with higher pre-procedural MDRO carriage. And there is significant variation in prevalence, species resistance and mechanisms of MDRO among the different countries. And there was only one validated method to assess duodenoscope contamination, that was microbiological culturing. But they have also suggested that future research is required to assess whether the current screening techniques like the throat, nose, and rectal swab culture, whether they can reflect the duodenal MDRO presence. The limitations of the study were it was conducted in tertiary care centers. So already the patients will be exposed to a lot of antibiotics, immunosuppressive agents, and baseline data were collected from local medical records, which may not be complete. And emerging pathogens like Candida auris were not included. And due to local resource constraint, culturing protocols may not be uniform among the 4 countries, and heterogeneity in patient characteristics and MDRO. Next is ulinastatin for the treatment of severe acute pancreatitis, a severe systematic review and meta-analysis. So this was published in BMC Gastroenterology Journal in September 2025. It was a systematic review and meta-analysis conducted by Bandyopadhyay et al. In ILS Damdam Hospital, Calcutta. So severe acute pancreatitis is characterized with the presence of persistent organ failure more than 48 hours with the presence of local and systemic complications. And ulinastatin is a serine protease inhibitor which inhibits neutrophil infiltration and release of pro-inflammatory cytokines and reduces systemic inflammation. So this review was aimed to assess the efficacy of ulinastatin in patients with severe acute pancreatitis and its effect on the mortality rate, the duration of hospitalization, the Apache-2 score, the white blood cell count, CRP, TNF-alpha, interleukin-6 levels, and the duration for disappearance of abdominal pain. It was concluded that early use of ulinastatin in severe acute pancreatitis was proven to lower inflammation and reduce abdominal pain by downregulating levels of interleukin-6, interleukin-8, and TNF-alpha. And there was significant reduction in mortality rate and duration of hospital stay. So actually they had started, this Kaplan-Meier analysis actually shows that there was a more significant difference in the rate of hospitalization and the days of hospitalization with the use of ulinastatin. But they had actually studied only 12 trials, and out of which only 2 were conducted in India. So strength of this review was it was a first meta-analysis to assess the efficacy and effect of ulinastatin in severe acute pancreatitis, and it adhered to the PRISMA 2020 guidelines, and it incorporated grade evidence assessment, and it includes recent studies. But the limitations were that there were smaller sample sizes and there was heterogeneity in the sample, so the generalizability were very limited. And there was a potential for country and institutional bias, and 2 studies were from the same group of investigators. So there can be an overlapping of the recruitment period and the treatment arm in them. Next is on the factors affecting recurrence of pain after surgery for chronic pancreatitis, a retrospective and prospective study. So this was published in Annals of Hepatobiliary Pancreatic Surgery in June 2025. It was an ampispective observational study, and it was conducted in Sanjay Gandhi Institute of Medical Sciences, Lucknow by Godra et al. So abdominal pain is one of the most prevalent symptoms of chronic pancreatitis, which can affect the quality of life of patients. And surgery is usually indicated in intractable pain in presence of symptomatic local complications, malignancy, and failure of endoscopic therapy. And recurrence of pain post-surgery is seen in 43 to 52% of cases. So the study had aimed to identify the risk factors for post-surgical recurrence in abdominal pain using a validated scoring system. So they had actually included all the patients aged 14 to 75 years admitted with chronic pancreatitis and who had undergone drainage procedures from January 2011 to May 2022. The IFSC, Intensity, Frequency, Consequence Score, and Pain Detect Questionnaire scores were documented before surgery and 6 months after the surgery. So this diagram shows the Frey procedure and the Pusto procedure which were used. The conclusion of the study was that among the total 125 patients who were studied, at follow-up after 35 months, complete pain relief was achieved by 43.2% of the cases. And there was actually a significant reduction in the post-operative IFSC score and in the pain detect score. So preoperative IV analgesics and endoscopic interventions increased the risk of post-operative recurrence of pain by 2.2-fold, and there was no evidence to suggest that neuropathic pain was a reason for recurrence. So early surgical referral for pain relief can reduce the risk of post-operative recurrence of pain, as concluded in the study. The strength of the study was it was only study which uses IFSC pain score, and limitations because of the retrospective nature, the small sample size, and it was a questionnaire-based pain assessment. Next is on the endoscopic ultrasound for nodal staging in patients with resectable cholangiocarcinoma. This was published in Journal of Clinical Medicine in September 2025. It was a single-center retrospective cohort study. It was conducted in AIG Hospitals, Hyderabad by Dejong et al. So, cholangiocarcinoma refers to malignancy originating from the bile ducts. It can be intrahepatic, perihilar, and distal. And the regional lymph node involvement is only a relative contraindication to resection. But CT and MRI have only an accuracy of 66 to 75% in differentiating malignant and non-malignant lymph node. So they have suggested that preoperative lymph node assessment by EUS could guide the treatment decision, that is preventing surgery in cases of metastatic lymph node or the potential use of new adjuvant treatment for patients with positive regional lymph node. So they had included consecutive patients with presumed resectable cholangiocarcinoma who underwent linear EUS preoperatively from January 2019 to December 2024. Suspicious lymph nodes were defined as having one or more following features: short axis diameter more than 10 mm, they were hypoechoic with a round shape and clear demarcation, fine needle aspiration or fine needle biopsy were done, and 135 patients were included, of which 12 were intrahepatic, 65 were perihilar, 13 were of middle, and 45 were of distal subtype. So this EUS actually shows the cholangiocarcinoma. And the primary outcome measured was the percentage of malignant lymph nodes found with EUS and the impact of EUSTA, that is tissue acquisition, on clinical decision making, analyzed in overall and by subtype of each cholangiocarcinoma. And the secondary outcome measured was EUSTA associated complications. So of the 135 patients who had been studied, only 71 actually underwent resection. So surgical exploration was actually precluded in 4.4% of patients with presumed resectable cholangiocarcinoma, mostly by the EUS tissue acquisition showing lymph node metastasis. And in intrahepatic, the yield was high of around 25%, whereas it was only 1.5% in perihilar. And it could not preclude surgical resection in 15.4% of cases with middle cholangiocarcinoma, and it could also help in delineation of the margins of lesion. And it did not influence clinical decision making in cases of distal cholangiocarcinoma because the EUS was done for other reasons and not for assessing the lymph node status. So it was concluded that EUS has a clinical impact in patients with presumed resectable cholangiocarcinoma. Strength of the study included that it was a single center study in a large cohort of patients from India. Limitations were lack of complete data due to retrospective nature. There was variation in indications of EUS and difference in lymph node station nomenclature. The last publication is Treatment Patterns and Survival Outcomes in Periampullary Carcinoma, a multi-centric retrospective study from the Indian subcontinent. It was published in Indian Journal of Surgical Oncology in August 2025. It was a multi-centric retrospective study conducted in 4 tertiary care centers in India by Sarath et al. So periampullary carcinoma refers to a group of tumors originating from head of pancreas, distal CBD and duodenum, and complete surgical resection remains the primary care of treatment, but recurrence rates are high of around 35 to 50%. So data on the treatment patterns and the clinical outcomes of periampullary carcinoma in India are actually less. So this study was conducted in 4 tertiary care centers in India, and 95 patients aged 18 years and older with periampullary carcinoma were included, and all the demographic details, the investigations, histopathology and treatment were collected. They concluded that the median age was 56 years with a slight male preponderance. Jaundice was the most common presenting symptom, followed by abdominal pain. And pathological staging showed that 35% of patients were in stage 1, 24 in stage 2, 17 in stage 3, and 22 in stage 4. And most patients presented with earlier TNN staging. So it actually reflected that there was an earlier stage at diagnosis and a higher rate of successful R0 resection. Ampulla was the most common site, followed by head of pancreas, distal CBD, and the duodenum. So this Kaplan-Meier analysis actually showed that the survival outcome was actually less in patients who were diagnosed with stage 3 and 4. And there was a statistically significant difference in the survival outcome between patients who underwent chemo and who did not undergo chemo. But there was no significant difference in patients in their survival outcome who had with different histological types like adenocarcinoma, intestinal type, and the pancreatic type. So they have concluded that early diagnosis and surgical resection remain the most critical determinants of survival, but the role of adjuvant chemo has to be further explored. And limitations include, because of the short sample size, there was a short follow-up period, and there was lack of molecular profiling for MSI, etc. Thank you.
Thank you, Dr. Anusha. That was a very extensive, comprehensive review of all the publications. It was nicely done.
Thanks.
Thank you. So in the ERCP cannulation study, was the technician experience included, or technician, how sound was the technician skill, was it included?
No, sir, they have not included.
I think that is a good this thing. When a technician is good, the requirement for papillotomy comes down in ERCP. It comes down very much in ERCP. Like, when I was with Ravi sir, we used to do a lot of papillotomies. But once I came to Apollo, there was no need for papillotomy. When Scindia sister was there, it was mostly done by her. So that I think that also should be included in the study, I guess. And anything else?
Dr. Anisha, I think that was an excellent presentation.
Thank you, sir.
The thing on urinastatin. We all know pancreatitis is prevented if it is given much earlier.
Yes, sir.
Why is urinastatin not a part of post-ERCP prevention of post-ERCP pancreatitis? Now you said that you
yes,
would
sir.
put a stent when you do a double guide wire.
Yes, sir. Yes, sir.
As a matter of routine for the prevention of post-ERCP pancreatitis, why is urinastatin not? Is it just because of cost effectiveness, or is it?
Actually, there are not much trials suggesting that. So we have to study on the utility of using urinastatin in such cases. And now, even the studies that have been reviewed, only 12 studies, and most of them were conducted in China. So only 2 studies that they have reviewed have been conducted in India on severe acute pancreatitis. So further studies are required on the utility of how we can use urinastatin in the prevention.
Long ago, when I was in All India Institute, Dr. Rakesh Tandon would prefer for difficult cannulation and for the double wire technique, urinastatin in a selected group of cases.
Okay.
150,000 units alone worked.
Okay,
The
sir.
lower doses did not work. So I was always wondering why this is not used as a routine. You're using non-steroidal anti-inflammatory agents rectally, you're using drugs. And then for the prevention of that severe acute pancreatitis in which you'll get into trouble, I think maybe in the guidelines,
Yes, sir.
somewhere we should get urinastatin for those patients in whom there is a high risk of pancreatitis following years.
That is an idea for a study as well. That can be taken as an idea for study as well. We can.
But actually, I think urinastatin is not taken off as one of the treatment guidelines. Even the guidelines don't say that, because the use of urinastatin is usually associated with a lot of adverse effects. I think people who have personally used, even I have used them earlier, I found them that they don't do well. The mortality rates are quite high.
Okay.
So I don't think the guideline never mentions about urinastatin here.
Yes.
Never mentions.
Yeah, there is a small.
I think there is a recent publication from India, from Calcutta, which has addressed the same question regarding the from Sandeep Pal and their unit regarding prevention of post-ERCP pancreatitis. A short-term urinastatin administration was associated with reduced incidence of post-ERCP pancreatitis, but again, it's a small single-center study I think they have done. So I think that's something that you can go through.
Okay, sir.
If there are no questions, thank you, Dr.
Thank you,
Anisha.
sir.
So now I call upon Dr. Bharat, a dynamic teacher who is going to teach the postgraduates. So it will be a postgraduate panel for refractory ascites and hepatorenal syndrome and acute severe ulcerative colitis. Over to you, Bharat.
Thanks, Piraman. Thanks, Anand, for those kind words. I don't know what I'm going to teach today, but then I want to say to the postgraduates, whatever you say, we were in a much worse situation at your age when we were studying, so don't bother. Feel free to answer whatever you know.
So I call upon the panelist, Dr. Y. Sriram from GEM Hospital, Dr. Ajay Dev from SRM Medical College, Dr. C.A.S. Bharat Kumar from Mayotte, TVS, Vaibhav from MMM, Kiran Hero from Apollo Hospital, and Shantan Reddy from Global. I think, can you raise your hands? Sriram, for Sriram, Ajay Dev, Bharat Kumar, Vaibhav, Kiran, and Shantan Reddy.
So there are going to be two cases. One is a liver disease and ascites. We have a 68-year-old male who's been presenting with complaints of worsening abdominal distension and fatigue with low-grade fever, also complaints of leg swelling and some shortness of breath and early satiety. And I just wanted to ask the first year PGMs. Here is Ajay Dev. And this gentleman is presenting with a history of past duration of 6 months, and it's been progressively worsening, initially with abdominal distension followed by leg swelling. And he gives a history of early satiety and some shortness of breath on exertion, one episode of passing black stools in the past, no complaints of abdominal pain, no complaints of fever. He's a diabetic with hyperlipidemia and metformin with a good glycemic control, and he's on statins as well. He drinks alcohol weekly thrice, 10 units per session for the past 30 years. And he's a non-smoker. So, clinical examination wise, vitals were normal. He had pulmonary erythema and spider angiomata on the chest, and abdomen showed a nodular liver with a palpable spleen, and some shifting dullness was there. And the labs showed some increased INR and low platelets, and with the age reversal in the mild transaminitis in the LFT panel, with a hemoglobin of 13. So, the first question is to Ajay about a template of history taking. How do we go about taking a good history, and what should you and how do you do that? Just give me the template, and then we'll go to the case as we go on.
So the onset and duration of the symptom should be asked first.
Then,
along with any other systemic symptoms like fever, weight loss, loss of appetite, any other illness.
okay.
And
So we go about asking like the demographic details first, and onset of the problem, progression of the problem, and how long has he been having the problem, any aggravating or relieving factors for the problem. And this will be your history of a presenting illness. And then you should have some associated relevant history which will help us to decipher the presenting complaint in a much better way. For example, here early satiety, like progression of shortness of breath on exertion, and some amount of history to rule out, because we are having a person who's having abdominal distension with leg swelling. There can be cardiac causes also, there can be liver causes also, renal problems and all those things. So some other associated relevant symptoms to decipher the history in a much better way, or the presenting complaints in a much better way. And then we step down to go about some etiological history taking to reason out whether it's going to be a liver related issue or a heart related issue or some other options. So that will give us a crisp idea how to go about investigating the person subsequently. And in the exams, if you're going to be the first candidate, you might be asked to give an elaborate history in detail, starting from all the parameters might be asked, and you might be lucky enough because you'll be spending like 10 minutes on presenting the history alone. But if you're the fourth candidate or the fifth candidate, the examiner might just ask you, summarize the history and tell. And Kiran, can you summarize the history a little bit from whatever I have given? Because the first step in your exam, the presentation, is how you present the history and how you summarize. That will give a good impression to the examiner to deal whether have you collected the history in a very template format, and you are able to assimilate the problem in the right way and give the summary in the right way. That's very important. Summarizing is invariably asked for most of all the cases. Even if it's a short history, they might ask short case, they might ask you to give just the summary. In our case, a 68-year-old gentleman, I have given some vague history. You can cook up some history also, but try to make a good presentable summary and say.
A 68-year-old male with background history of diabetes and dyslipidemia and with significant personal history of alcohol intake, presenting with painless progressive abdominal distension associated with pedal edema and decrease in urine output and shortness of breath.
So
and
if
and
you look
only
at this summary,
and
I've
one-
given a very crisp summary, which
Yes,
will give you an idea how we go about.
Yes, sir.
So I've given how the presentation is, and I have given some associated progression history, and how I've tried to rule out an etiological problem by giving a PND and orthopnea history and trying to rule out some sort of a cardiac component is not there. And I've given some history about fever and chronic cough to rule out if there is some tuberculosis or infective etiology for, because those are all the lead questions. If you are confident, you can lead the examiner to ask certain questions which you might be very confident in asking or saying, answering them. And also he gives history of passing back stools, but no obvious history of hematemesis, no history suggestive of jaundice. So there are some positive histories and some negative histories which are summarized in a crisp way, so that you will have 3 or 4 possible differential diagnoses for which you know the answers very well, so you can lead the examiner in the right direction, so they can ask questions straight away from those things. So, and I have given one loop for pulmonary tuberculosis, thinking that if he is asking whether if it is, could be tuberculosis peritonitis, will I be prepared for answering those type of questions as well. And no history of jaundice and alternative medications. And of course, alcohol excess I have given. So first lead, what do you mean by alcohol excess? Do you know how to quantify alcohol intake? Might be a question for which you should be prepared to answer. So the unit levels and percentages, some common things you should know. The demographic detail, if some sort of a resident area which is very rampant in certain type of diseases, usually not very much involved. But in this question, in this summary, what are the possible questions, lead questions they might ask is, one question is, I've left with open statement of an alcohol excess, so they can ask you to quantify alcohol intake. And I've said painless progressive abdominal distension. They can ask you, can you give some few causes of painful conditions? They can. So you should be prepared because the examiner is going to take the questions from what you say. That's a straightforward way how they deal a candidate in an exam. So, and then I have asked for non-hepatic causes. Is that then the next question is, I have given a lead for a few cardiac history, non-hepatic causes for ascites or abdominal distension you can be asked for. And tuberculosis, if you tuberculosis ascites, there is a reason for infective cause, they can be asking you those questions. And history of alternative medications and alcohol intake. So from this summary itself, you can expect some sort of a lead questions from the examiner, and you should be confident enough to try and lead the examiner in the right direction, so that you will be very good in answering those questions. So from this, what do I mean by have you got a template? The examiner will easily understand if you jump from one point to another point, and if your summarizing goes in a very random way of one initially about progression and then about alcohol history and then about some sort of a jumping from top and bottom, then he might not be giving a very good impression to the examiner. So summarizing and doing a detailed history and presenting in the right way is very, very important. And having a template format for history taking and writing it down in the way how you want to present will be a very easy and a useful way how to handle your exams. So this is how you will try to lead the examiner that's how from this history they will ask you what are the possible differential diagnoses and some significant points. And the examiner always feigns in ignorance, and they will ask, can this be pancreatic ascites? And don't be very abrupt in saying that I don't think so or something like that. You can always use polite versions like unlikely, because the person doesn't give any history of significant abdominal pain, and there's no sudden onset abdominal pain, and the history doesn't look for an acute pancreatitis, because they know very well you are going to commit on a chronic liver disease. But then they will ask you questions like, can this be pancreatic ascites, or can this be tuberculosis cause? And in which case, unlikely, because possibly, but can this be an acute Budd-Chiari syndrome? If they're going to ask you about an acute Budd-Chiari syndrome, possible, but there are certain points which are not favoring an acute Budd-Chiari syndrome. Likewise, an upper abdominal pain, a short duration ascites, the person has been having a progressive distension for a longer duration. So this is how you will go about tackling the history and summarizing. So, but if you have been very, very sloppy in your history taking and your presentation, then like how they say in MD, define pulse or what's a pulse wave, the examiner asks questions like that, I think you are on a very slippery slope. So, these are all certain some questions which they ask if they what name, tell me the 4 signs of shifting dullness or things like that. In which case, we don't want the examiner to ask you questions like that, because that means that you are in a very sort of a danger zone. So, I'm going to ask Sriram about pathogenesis of ascites. Do you know anything? These are all, if an examiner is a very simple, straightforward examiner, the next question could be, what's the pathogenesis of ascites? So, in a person with chronic liver disease.
Sir, there are multiple mechanisms for pathogenesis of ascites. One is there is decreased effective blood volume. Because of this, RAS pathways get activated and there is increased sodium retention, which can cause ascites. And there is also decreased lymphatic flow, which can cause ascites formation. And mainly these 2 mechanisms will be.
So they would want you to know certain keywords you have to use, like splanchnic vasodilatation causing an increase in sinusoidal pressure. Likewise, if you use the words which the examiner wants to hear, these are all things you will easily learn, but how you will put across to the examiner is that you want to put the right words so that they will be quite happy, because he wants to listen what he wants to listen. So you need to give in the right words so that you will be able to tide over questions like this, because these are all straightforward questions wherein you will have to be clear and upright in how you present. So these are all there, all in your book, so you can always go and read. That's how you will go about. If they are going to ask you a straightforward question like pathogenesis of ascites, tell me how ascites is happening, and in which case you need to say, in cirrhosis there is splanchnic vasodilatation which is causing arterial underfilling, so sodium retention, plasma volume extension, ascites, or else increased sinusoidal pressure, more lymph formation leading on to ascites. So that is how the subsequent questions, if you are going ahead, and then if he is going to ask you some lab tests, and then if he is asking about hyponatremia, dilutional, secondary hyponatremic state, all those things you can answer. But straightforward questions, always be clear about the keywords. You need to be really, really correct, and using those right words will help us to tide over certain simple questions, because you're going to be with them for at least 45 minutes to 1 hour, and if you're able to answer certain things which you know really well, that will give you a good impression. And now, how do you classify ascites? I will ask Bharat Kumar on that.
High sag ascites with high protein high sag, low protein high sag, and low sag with high protein and with low proteins.
Okay. So whenever you go in for any questions, if something like how do you classify, if you can identify like some 1 or 2, if they ask you what are the possible causes, surgical causes or non-surgical causes, if you are able to answer your questions in categories, that creates a very good impression. For example, if you ask, look here, based on the amount of fluid accumulation, it is classified as, that is a subcategory. So when you answer like, based on the amount of ascitic fluid, it can be mild, moderate or severe. Based on response to treatment, it can be, because you are at an advanced level, so you impress the examiner if they ask you questions like this. So you try to subcategorize. If based on the amount of fluid, it's mild, moderate or severe. Based on the responsive diuretic responsible to recurrent ascites or refractory ascites. So in which case you have already given, you have professed that I know certain things, so you can try and ask my questions like that. So if they ask you questions, if there is a chance or if there is a possibility, if you can categorize and answer, you please categorize and answer, in which case it will be a very good way of trying to impress the examiner. So in this case, based on the fluid, and based on the responsiveness to treatment. It's all there in your books. When they ask you questions, how you answer is how it matters. So, what are the investigations and what tests in diagnostic paracentesis? I'll ask Vaibhav on that.
First, we will look at the physical appearance of the ascitic fluid, color,
Okay.
quantity, whether it is mixed with blood or chylous ascites, depending on that. Next, the biochemical analysis of the ascitic fluid, like ascitic fluid protein levels, albumin levels, total counts, differential counts, LDH, cytology.
So it's an open labeled question. What are the investigations was the question. So as I said to you, try to categorize and answer. If you can categorize and answer, it will be much useful. Make an attempt. Like how based on fluids, based on responsiveness to treatment. And what are the investigations? We have got a person with chronic liver disease. Yeah. By this time, we have understood that.
Blood investigation.
Because we are dealing with ascites doesn't mean you need to answer only about ascites. The question is open labeled.
So blood investigations, complete blood picture, look at the hemoglobin value, platelet value, MCV value predominantly. Next, liver biochemistry, look at total bilirubin, direct and indirect component, transaminase levels, total protein levels and albumin levels, look for hypoalbuminemia specifically, and any AG reversal in the patient. Next, renal biochemistry, look at serum creatinine, urea levels and serum electrolytes levels. Next, PT-INR value to rule out any underlying coagulopathy for the patient. Next comes the ascitic fluid analysis. In ascitic fluid analysis, physical appearance of the
some other tests other than labs, some other tests,
ultrasonography. Next comes imaging. Imaging ultrasonography. Look for the underlying liver, spleen, any presence of portal vein diameter, presence of any collaterals, and underlying kidney.
So if you answer, I will investigate the person by doing some basic blood workup and an ultrasound and some ascitic fluid analysis. In the blood investigations, I would like to ask all these things. So always try to categorize and answer. So it will be, if you give a heading, so it will be much easier how you answer to the examiner. And in paracentesis, what do you look for?
So look at protein levels and albumin levels. Based on that, we categorize whether it is high SAG or low SAG and whether it is high protein or low protein. Depending on that, if it is high SAG and low protein, it is because of underlying cirrhosis. High SAG, high protein is post-sinusoidal causes like congestive cardiomyopathy. And with the low SAG and high protein, rule out malignancies or tuberculosis.
Okay.
So, and cytology reports.
So high SAG indicates predominantly portal hypertension. And with the high SAG and low protein, high SAG and high protein, you categorize. And then SAG less than 1.1, predominantly peritoneal diseases, mostly malignancy and tuberculosis and things like that. So that will guide us to decide what other subsequent investigations you want to do. So name a few non-hepatic causes of, I've asked all. Santan Reddy will answer on non-hepatic cause of high SAG ascites.
Transrate will have high SAG ratio, sir, and
this is the question. Examiner, one examiner asked me, what is the literal meaning of diarrhea? That was my question which was asked. So at times you will be thrown up certain questions for which, if you have been listening to, we had one veteran with us who had notes of all the examiners, so I was able to answer that question straight away. So.
Cardiac ascites.
Okay.
And renal etiology, cardiac and renal ascites can be translative ascites with high SAG ratio.
Because certain examiners might want to completely deviate and ask a few questions like this to see whether, but non-hepatic causes, just get to know. We need to know about all these things when we deal a person. Ascites is a straightforward case presentation, so at times you might be asked questions like this, or name a few, because if you keep presenting and to various people, they will ask lots of questions, and just make a note. When you revise, it will be much easier for you at that time. So CCF, constrictive pericarditis, nephrotic syndrome, severe hypoalbuminemia, protein losing entropy, myxedema are all some non-hepatic causes of high-SOG ascites. So SOG interpretation, I'll ask Kiran again. The same things only. So this you will know. So we'll go to Kiran for the treatment principles. How do you treat ascites? As an outpatient, as an inpatient, or whatever. Try to categorize and then answer. How do you treat? What are the treatment principles?
Initially, we should look for any other coexisting decompensations, and if mainly to rule out any kidney injury or any SBP which makes it a complicated.
This gentleman has got normal renal parameters and he has got progressive distension with no major alarm features as such. So he is not jaundiced. He is not having any bleeding. His hemoglobin is holding on quite well. Normal creatinine. And how do you treat this? He is in your OP. How do you treat him?
This will be a patient of first episode of decompensation of an underlying chronic liver disease in the form of ascites.
Okay.
My first treatment principle will be to assess his weight, renal output, and try to for the mobilization of ascites with pharmacotherapy. The pharmacotherapy varies between IP and OP admission. For IP, I will try to start him on spironolactone along with diuretics, Lasix. I will maintain the dosage ratio in 100 mg to 40 mg ratio, 100 mg of spironolactone, 40 mg of Lasix, and I will try to I will initiate him on Lasix-lactone 40 per 50 mg twice daily, and do a daily weight monitoring. And I will my aim for weight changes up to 500 gram reduction in weight per day if patient is having.
So that's the next question. How do you assess response? First, you will go about very important thing is your
dietary
sodium restriction. First step is sodium restriction. So you need to make sure he takes 2 grams per day. So good salt restriction is the first step. And of course, most of them will require diuretics as well. And in the person, how do you assess response is by expected weight loss. If they are having peripheral edema, 1 kg per day. If no peripheral edema, 0.5 kg per day. So first diuretic of choice, always spironolactone. You begin with 100 milligrams and max go up to 400 milligrams. How frequently, how do you assess aldosterone responsiveness? You will dose titrate every 3 days once, after every 72 hours, not on every other day. Not expecting, if you're not expecting the result, don't do it on the next day itself. You wait for at least 3 days to increase the dose. And loop diuretics, furosemide is the choice, and 40 milligrams, max is up to 160 milligrams. Usually a combination, if you are suspecting some sort of a renal impairment also, then you might start with the low dose of spironolactone and some loop diuretic as well, because of risk of hyperkalemia and various other correcting hyponatremia as well. So salt restriction and diuretic therapy is the fluid mobilization part. General concepts for the liver disease, you will have to concentrate on nutrition. What is the protein intake you will try to advise?
1 to 1.5 gram per day,
per kg
per day, 30 to 35 kilocalorie of per kg.
Right. So how do you assess the response? We have already gone through that. And a note on urinary sodium. Do we have any other parameter to monitor? I have given the clue. I'll ask Sriram about what else other than your weight reduction, every day expected weight reduction. How do we go about monitoring the responsiveness to therapy?
Sir, first.
Any other test you will do?
Urinary sodium excretion, sir. It should be more than 78 millimoles, or it should be more than what the patient is taking, salt intake.
Okay. So he is taking 2 grams. So how much of 24 hours urinary sodium you expect?
80 millimoles.
More than 2 grams is equal to 90 millimoles, what they say. And if you are expecting a good natriuresis, it definitely should be more than that. So in that case, you will expect definitive fluid loss. The person is passing 100 millimoles of sodium, but then still not losing weight.
whether the patient is adherent to his sodium restriction or
So
not.
dietary restriction, is he compliant with this dietary restriction will be the next option, which you will infer from 24 hours urinary sodium. So the output should be more than the intake, and if the output is more than the intake but still no fluid loss, means he is not being very compliant to his sodium restriction. 24 hours urinary sodium is quite cumbersome to collect. Can we do any other measure? Bharat, can we do that? Or anyone can answer. Do we have any takers for that other than 24 hours urinary sodium? Do you have, which is easy?
Urine spot sodium we can do. So
Okay, spot sodium to
by potassium.
ratio. Why so? What's the principle? Do you know by any chance? Okay, what's the ratio you expect?
More than 1,
Okay,
less than 1.
so sodium excretion should always be more than potassium excretion, and if it is more than 1, then the person is having adequate natriuresis and there should be fluid loss. The sodium potassium ratio is more than 1 but still not much of a fluid mobilization, then he is not being very compliant. If it is less than 1, there is definitely scope for increase in diuretics. With the normal parameters, we can gradually keep increasing the diuretic dosage. So in spite of full medical treatment, patient is still having a recurrent abdominal distension. And what is the definition for refractory ascites? Santan.
Patient requiring not once after the therapeutic paracentesis is done, or patient refractory ascites is diuretic intractable or diuretic resistant.
Okay.
If the diuretic resistant ascites, patient will not respond to the highest dose of spironolactone or furosemide, 160 and 400, and or reaccumulation of ascites within 4 weeks of doing a large volume paracentesis is considered refractory ascites.
Okay, so refractory ascites can be diuretic resistant, as you rightly
Intractable,
mentioned, and
developing
diuretic
of any
intractable.
complications
And,
on continuing usage of
correct.
diuretics.
And the survival rate is poor if they are going in for a retractable refractory ascites. And 5 to 10% of the cirrhotic patients will invariably go in for a refractory ascites. And pathogenesis being, you assess for diuretic response. If they are not, then if they have the various complications happen because of diuretic usage, or if they are not mobilizing with the full dose, we call them as refractory ascites. And the primary treatment for that will be
Large volume.
Okay, go on.
Large volume paracentesis with albumin replacement. Sir.
So what's the dose of albumin you give?
We give 8 grams of albumin for every liter of fluid drained.
Okay, and how much max you can drain? What's the problem if you drain
Post
too much?
paracentesis circulatory
8
dysfunction.
liters we can drain. Up to 8
Excellent.
8 liters you can.
Then what happens if you don't, if you take more than 8?
Post paracentesis circulatory.
risk.
How does it manifest?
Because of excessive fluid loss from the abdominal cavity,
Correct.
there will be lesser venous return to the heart, so less blood supply to the vital organs like kidney, and reduction in urine output will be there because of
So
low
what all complications
renal
happen because
plasma
of
flow.
that?
Low urine output, increase in creat, HRS.
HRS,
Is
encephalopathy,
possibility,
even
encephalopathy.
death can all happen because of a massive fluid shift. And it can happen. To prevent that, we try to give albumin for every liter, 8 grams of albumin is replaced. And is there a condition wherein for a smaller volume of ascitic tapping, you tend to give albumin? Any condition? So these are all questions for Pirama-like students. No, Pirama, I am like Padip all will be asked questions like this. When can you give? When do you give albumin if you are having? Even if you tap a smaller volume of fluid, do you give albumin? So there are certain conditions wherein if there is a hemodynamic instability and patient is having a lot of problems because of the fluid, and if there is an acute kidney injury or the SBP is low, or hyponatremia, albumin infusion to be strongly considered even for a smaller volume of paracentesis. So the whole point of doing paracentesis, large volume paracentesis, even though you try to prevent PPCD, you always give albumin for any amount of fluid taken above 5 liters. Lesser volume you tend to give whether there is some hemodynamic instability or hyponatremia or an acute kidney injury. So, anyone can answer on ANSWER study and MARCH study?
ANSWER trial is a positive study with giving albumin to prevent HRS. The study goes like we have to replace albumin every second week up to first 12 weeks, then followed by up to 18 months. And it has shown to show that incidence of HRS in the patient who have received albumin was less. MATCH trial is a negative trial which has not shown any improvement even after giving albumin.
They used both albumin and midodrine, and they found they didn't make any improvement. Whereas there was a good reduction with in the ANSWER trial. There were good reduction in complications even by using long-term albumin. So our case, this patient is done. Our patient underwent liver transplant, is doing good for now. So we'll get on to the next. So this is straightforward theory questions, but then a 20-year-old male, known patient with left-sided colitis on oral mesalazine, presents with 15 bloody stools, severe lower abdominal pain, fever of 38.6 degrees, blood pressure of 100/70, CRP of 165, hemoglobin of 9.5, albumin of 27 grams, and stool cultures negative. We'll start from here to that. I'm not going to call. The questions are one by one, you'll answer. So how do you assess the severity? And what is the severity in this gentleman?
True love widths, it is severe, sir. And bloody stools more than 6, and with abdominal pain and temperature more than 37.8 degrees Celsius, and with hypotension, CRP more than 30, and hemoglobin levels less than 10.5.
So true love and widths, as I said, you can always categorize and answer a bit more. Now is your chance. If you know that very well, just say what are the parameters used. How do you categorize?
We'll use heart rate, stools, bloody stools per day, heart pulse, temperature, hemoglobin, ESR, and CRPs.
So here our gentleman had quite a bit of, he has got some temperature and he has got bloody stools and his CRP is way high and his hemoglobin is low and his pulse rate I haven't mentioned, but everything fits along with the severe in case of as per true love and widths modified criteria. So this gentleman who's been on just oral mesalazine alone has gone in for a proper flare presenting to us with a severe colitis. Management in the first 24 hours. Next one.
So we have a inflammatory colitis presented with severe flare. So first management would be first general condition, hydration status. Then we'll go for labs. In laboratory,
it's there. It's already there. So how do you manage?
So first we will get an imaging done for the patient.
He has come to your OP. Now go. The examiner feigns ignorance. No, I don't know anything. What will you do? Will you treat him as an outpatient?
No, so we will admit him first.
Okay.
We'll admit the patient. Next, vitally we will try to stabilize the patient by giving IV fluids. Then we'll look for laboratory investigations. In laboratory investigations and imaging, we will first get an X-ray abdomen to rule out toxic megacolon or any perforation. Look for thumb sign also. And next would be initiation of corticosteroid in the, first we will do the unprepared colonoscopy, take biopsy to rule out any underlying infection which have flared up the inflammatory this thing. So in sigmoidoscopy we will take biopsies for CMV colitis and stool sample for C. diff, presence of C. diff. If it is present, we will treat it. Then we will go for giving a patient steroid. And we will assess hydrocortisone 100 mg Q6 hourly or methylpred 60 mg per day. Then we will try to assess the patient on third day of presentation, and we will look at stool reduction. If it is less than 8 or more than 8 with fecal calprotectin levels.
I will come to those. So you will do the basic test, lab test, confirm the severity, do an X-ray or a CT if need be, rule out any perf or any toxic myocolon, go ahead with the sigmoidoscopy, take some biopsies to rule out infective complications, and then you will start on treatment, general measures including IV fluids, stabilize the patient quite well, and start disease-specific therapy in the form of IV corticosteroids. And if there are any electrolyte abnormalities, and you will go about correcting those. And nutritionally, try to start them on enteral nutrition as early as possible. TPN preferably avoided in the early state. So, the person you have treated, Kiran, what you will do on the third day, the person has got still 10 bloody stools and the CRP is 120. How do you assess? Is there any criteria to assess this?
We use Oxford criteria to assess this. The stools are more than 8 and also CRP is more than 35. So patient is non-responding to steroids. So we should consider rescue therapy for this patient.
Okay. Is the Oxford criteria, what for was it used? To predict what?
Predict steroid response in
and
colectomy rates.
Okay. Has it been very relevant now?
No.
Is it being very now?
Now we are
it's still used, but not predominantly for judging a person who is to go for colectomy, because the incidence have reduced with the new advent of a lot of newer medications. So it is still used to identify who are all the candidates for rescue therapy. Not for colectomy per se, but still used for, but predominantly for people who are going in for rescue therapy as such. We'll skip Ajay. We'll go to Bharat. Oh no. No, not Bharat. The next one. Santan.
Yes.
And Oxford criteria is used basically to identify people who have steroid responsiveness. How do we categorize? That's there.
Complete responders with stool frequency of less than 3 per day, and incomplete responders having a stool frequency of 8 per day and CRP less than 45, and non-responders more than 8 stools or more than 8 stools, or more than 3 stools with CRP more than 45 mg.
Okay, so our gentleman falls into a non-responder. So he is not responding to steroids. So what do you do now?
I would like to consider this patient for rescue therapy with cyclosporin or infliximab, but commonly we use infliximab as a rescue therapy of before 5 mg per kg body weight, IV dose, followed by 0 to 6 and followed by 8 weekly dose as maintenance we use, sir.
Is there an entity called accelerated induction?
Yes, sir.
When albumin is less than 3, we can go for it.
Okay. And what do you do in that?
Increase the dose to 5 to 10 milligrams.
No, accelerated induction is not increase the dose.
So
it is 0, 1 and 6. You reduce the duration to 0, 1 and then go to 6, not 0, 2 and 6. So you go for infliximab. Why not cyclosporin?
Either of it we can choose, sir, based on the patient. If the patient is naive to thiopurines before, then any failure of thiopurines in the past, if it is present, then
why not cyclosporin is a preferred drug?
It has complications and we cannot use for very long durations, sir. Only we can use for 3 to 6 months, and with
risk of hypertension, risk of lots of other nephrotoxicity is all there, and you need to monitor the dose troughs as well very periodically. Yes. So not a very easily usable drug. So we have most of expertise with infliximab. So you start with 5 milligrams per kg as an induction, which is standard 0, 2 and 6. Yes. If it is accelerated on people who have got severe colitis, it is 0, 1 and 6. Do you use any dose increase? 10 milligrams can also be increased if the person is presenting with severe colitis. So, and when do you consider surgery?
Sir, when there is non-responsive to steroids, or if the patient is also not responding to rescue therapy, if there is any complications or toxic myocolon or complications like perforation or peritonitis.
Excellent. So rescue therapy, non-response, toxic myocolon, colonic perforation, dysplasia or cancers, severe hemorrhage, delayed deterioration after initial response. These are all certain common places wherein the surgeon comes in, and what surgery they do?
Colectomy or subtotal colectomy with diversion ileostomy.
Okay, perfect. So, what are the predictors of steroid failure? Kiran? So these are all questions which you might have to read. It's all there in the guidelines. So what are the predictors of steroid failure? You just read it out.
CRP more than 45, serum albumin less than 3 gram per deciliter, deep ulcer, day 3 high stool frequency, prior dependence on steroid, severe colonic dilatation, and CME colitis.
Yes. And Bharat, toxic megacolon?
Dilatation of the bowel more than 6 centimeters, and presence of high grade fever, temperature more than 38 degrees centigrade, along with abdominal distension.
So what are the early predictors? When do you tend to be a bit more careful about toxic megacolon?
Dyselectrolemia, mainly hypokalemias.
Then fever, abdominal pain, tachycardia all indicate that there could be some other underlying pathology. So make sure you do some sort of an imaging before we embark onto any sigmoidoscopy or whatever. So I've got 6 more minutes for all my senior teachers to ask them any questions. Thank you, sir.
That Bharat, Bharat, that was really spoon feeding. It was real spoon feeding. Unfortunately, there are less number of postgraduates. Pirama, I think you should make a plan to rope postgraduates rather than roping me in.
Actually, very simplified and very engaging presentations. That's very nice.
I mean, this is a question that was asked to me in my DM examination by Dr. B. N. Tandon. He wants the answer from Schlesinger's textbooks of medicine, 1984. The answer is enough to wet your peritoneal surface, which are about 5 to 10 ml. How much of fluid should be present to be detected by ultrasound?
15 ml.
Huh?
50.
According to who is this? You? 150 ml. 100 to 150 ml. That is the amount of fluid that should be present in the acidic fluid for you to detect by abdominal ultrasound. What are the causes of distension of abdomen in whom there is ascites, but you don't see shifting dullness?
Loculated ascites, sir. Any
This is by undergraduate loculated ascites. You are a postgraduate.
enteroenteric enteroenteric fistulas in Crohn.
Fistula. If the ascites is very tight, then it won't shift. There is no area to shift. Then there is short mesentery. If the patient has a short mesentery, then you may not be able to demonstrate shifting. These are things that are present in that book, but it is not present in the subsequent editions of Schlesinger.
Yes. So one book which you should all read for abdomen is our clinical case surgical handbook, Das textbook. You should have that book you should read. So I hope it was quite useful. Sir.
I just have one question that was not mentioned. Stools checked for C. diff before treatment planned on?
Yes, sir. Stool will be checked for presence of C. diff toxin and GDH.
It was checked and it was negative.
No.
Yes.
No. This is a hypothetical presentation to keep them, sir. So this is not this is not a presentation from. I mean, not one of my patients as such.
All right.
So what are the arguments of midodorine? So midodorine is given for assisted arthritis. So what is the can be using?
Whether midodrine can be used as a replacement therapy for albumin. Because even albumin need not be given if you do a large volume paracentesis. If you give midodrine, that is enough to prevent paracentesis-induced cardiac dysfunction. And another one is recent trial is going on for midodrine plus clonidine for resistant ascites. And what is the role of the sodium glucose co-transporter 2 inhibitor? The first patient is a diabetic patient. So he has got a resistant ascites. Why don't you use dapagliflozin? Dapagliflozin is also reduces the ascites and the pedal edema. If the patient is a diabetic, not non-diabetic, diabetic patient.
I think we'll close. Oh, thank you very much, sir. Thank you guys for that patient rant from me. Right. Thank you, sir.
Thank the chairpersons and Dr. Bharat for taking us through this wonderful postgraduate panel. And I also was impressed with the presentation by Dr. Anusha as well. It was pretty thorough with the recent publications. So I hope there are more postgraduates who could have benefited from this. So before we move to the CME part of it, I'll just briefly present the secretary report. So last month we had a wonderful midterm meeting at CMC Vellore. Congratulations and thanks to Dr. Epan and Dr. Ashish Goyal and the entire team of hepatology who were instrumental in conducting it. And there are about 120 registered participants who took part in this one day, basically 6 hours meeting, and it was well attended, participated. And last week we had our eCME, that is mainly for postgraduates who are not able to come or attend in person, like in postgraduates who are doing their training outside of Chennai. So we had the 9th session of this Tamil Nadu ISG CME, and I thank the Coimbatore Medical College team for organizing it. And there were about 60 online attendees who benefited from this deliberation. Congratulations to Dr. Nirmala. She's not able to come around, but I wish her well for the subsequent role after she retires. And I'm very happy to announce that she has been elected as the president of the Indian Society of Pediatrics, Gastroenterology, Hepatology and Nutrition. So best wishes to her on our behalf. I'll hope she will be joined today. On the same note, I'd like to announce that last year we started the Tamil Nadu Postgraduate Travel Grant. So the second member, we already gave one grant to one of the postgraduates from the ICH. The second member who was selected from the ICH, she has also gone and presented her work at Italy last month. Unfortunately, she's not able to join here due to some personal reasons. Otherwise, we are planning to give her the grant amount today. So probably next meeting, we'll be providing her with the grant amount. So congratulations to her. The Tamil Nadu ISG HCC study is still ongoing. I think the IEC approval has been obtained from most of the study centers. I think some of the centers have started collecting the data already. So key forthcoming meetings. We have our annual meeting that is from December 3rd to 6th at Amritsar. I hope many of us will be joining the national level meeting. And the subsequent annual conference of our society is from 30th Jan to 1st February. 30th will be a postgraduate session. 31st and 1st will be the main conference conference, and it will be at Yerkad. And the Salem Gastro Society is making arrangements for the same. So to new academic trainees, I find very little people here, but I request all of you to become student members of the Tamil Nadu ISG. Fill up the online application form and submit your fees. And please enroll as members of the national body also. And before we move to the CME part, I request you to scan the QR code that is placed on your table so that we can send this across for the online CME points from the Tamil Nadu Medical Council. And this time, the CME part is mainly coordinated by Dr. Seshadri from Apollo. Thank him for taking the steps. This will be about preventive care in gastroenterology. for taking it forward, I request the chairpersons, Dr. L. Thayumanavan and Dr. Lognathan, to conduct the proceedings, please. Please come. Thank you.